Well, hello everyone. Welcome to this virtual global spine conference meeting, weekly meeting. We have today the honor of having a friend. We host Ignacio Barrenechea. He's a very close friend of mine. He's a neurosurgeon, fellowship trained at St. Luke's Roosevelt in New York under the chairman of Dr. Noel Perrin. He's a phenomenal surgeon. He's a very skillful surgeon. So we'll see the cases he wanna show us. It's open to discussion, so please share your questions in the chat section. I will try to collect them to do that for Ignacio. Ignacio, welcome.
Thank you for the invitation. I have a couple of cases, 2 or 3 cases that I wanted to share with you guys, which really I learned a lot from these cases. And well, if you want me to go right into it, I will share my screen. Should I share my screen, Alfredo?
Yeah, sure, please. Got it, perfect.
Okay, should I start?
Yeah.
Okay, so this is a 27 years old patient, male patient, who came to my office last year with progressive weakness in his 4 limbs, more so on the left side. His arms were 3 out of 5, and his legs were 4 out of 5. Had a kind of a central cord syndrome, and also he had a broad base, unsteady gait when I had him walking. So he came with an MRI. Let's see here, in which you can see the dentate tip with the C1 arch and a subluxation with severe compression of the spinal cord there. You can see it was really dramatic. And the guy had seen many surgeons before, and really, the options were a lot. The guy had received a lot of opinions, different opinions about what to do. The ADI, the PDI were really altered, and he had a severe compression right behind the base of the odontoid process. It was not behind the odontoid tip; it was behind the odontoid base, and he had this hypertrophic PLL compressing the spinal cord, kind of buckling and compressing both the spinal cord and the anterior spinal artery. And this is another axial cut in which you can really see the severe atrophy the guy had. And I ordered him a CT scan, in which, again, you can see the anatomy there with the severe compression. His canal was 9 millimeters. You remember that less than 13 millimeters is a critical compression. And we diagnosed an orthotopic os odontoideum based on the images. So our treatment algorithm was Halo-Vest traction on Monday. The Halo-Vest was good because we had the guy eat and swallow for a couple of days, just to make sure that the head position was good. Then also the traction made by the Halo-Vest allowed us to kind of correct this malformation. And then on Wednesday, we had a transoral basal odontoidectomy. And then on Friday, we did a C0, C5 fusion. So why I keep saying a basal odontoidectomy? Because if you see the CT scan with the cut along the canal, you can see that it was the base of the odontoid process what was compressing the spinal cord along with this hypertrophic PLL. Severely compressing the spinal cord and the anterior spinal artery. So this is our patient with Halo-Vest. Again, it was very important to have him eat for a couple of days and make sure that position, that specific head position, allowed him to swallow properly. This is the pre-op X-ray with you can see I draw the position of the C1 and C2 bones. And then this is the X-ray with the halo vest. So on before we order an angio CT scan to see the position of the carotid artery before doing the transoral surgery. So on a Wednesday, it was funny because it was a holiday in Argentina that day, so the anesthesiologist wasn't that happy to do these kind of cases on a holiday. But so he underwent a tracheostomy first. He had a microapnea, as you can see there. So really, the guy was all not well formed. So, but we managed to put a retractor and make our way down the base of the odontic process. So this is a short video showing the basal odontoidectomy. We did that with the burr because it was really deep, as you can imagine. And so the idea was to remove the cancellous bone first until we reach the cortical bone behind, and then go with the kerrison. So this is our bone work with the burr. And once we drill the cortical bone, we put a kerrison ronger, 1 millimeter, and you can see the X-ray now where we are with the ronger. And then we removed that hypertrophic PLL that we saw on the pre-op MRI. And by removing that ligament, we managed to decompress the spinal cord. You can see at the end of the procedure, we fill the cavity with the radiopac contrast. And we felt pretty happy with our decompression. Also, you can see the traction made by the halo vest kind of reduced the malformation, and the canal was already widened. And this is the C-arm sequence for you guys to see what we did that day. And again, we felt very happy at the end of the procedure. So this is the immediately post-op X-ray performed in the ICU, post-traction and basal odontoidectomy. You can see that the canal, the PADI has widened. So on Friday, we adapted the halo vest to the Mayfield head holder arm, and we did a C0, C5 fusion. It's important to put their autologous bone. We put iliac crest. This is a post-op CT. You can see there's a JP drain, and this is comparing the pre-op and post-op images. And this is the screws. We managed to put just one pedicle screw on C2 because, as you can see on the right side, the one of the vertebral arteries was really high riding, and we couldn't place a pedicle screw. Even the one pedicle screw that we put was really close to the VA. So we felt happier by going down to C5. This is the autologous iliac crest bone bridging the Z0 C2 space. It's important in these cases to do autologous bone fusion. And also, given the pressure that these contracts support, it's important to go to the keel of the occipital bone and put screws there to avoid pulling of the screws later. So just to remind you guys, this is the pre-op, and this is the post-basal odontoidectomy, which you can see a nice decompression of the spinal cord at that level. And this is the pre and post-op sagittal T2 MRI. One wonders how this guy managed even to breathe or walk with this kind of severe spinal cord compression. The guy came to my office walking, so I was really scared of doing this procedure, but he did very well. Of course, he had complications in the post-op. He had a right side pneumonia like 10 days later after the OC fusion. He went back to the ICU he was with IV antibiotics, and then he did a right side pneumonia again. A left side pneumonia on the other side, and he also went down. Once he was in the ward, he went down to the ICU like 10 days later. And he developed a hypercapnic respiratory failure after the surgery with severe sleep apnea. So we had him like 7 weeks in the hospitals, but we managed to transfer him to a rehab center after these 7 weeks. So it's important to acknowledge that this patient can have pulmonary problems even pre-op, and it has been described in many papers. You have to know that this can happen in the post-op. And this guy, talking with this guy, he like 6 months after the surgery, he told me that he had already had some kind of a shortness of breath when lying down like 2 months before the surgery. So the guy recovered all his, I would say 90% of his motor function. This is a picture I took in this same office I'm right now on 10 months after surgery. And this is the last X-ray I have, like 10 months post-op. So as you can see, there's some loss of the initial reduction, but the guy is doing really well. He's currently pain-free, and he's working from home. He's a software developer, and of course he still uses a CPAP machine at night, but he's doing really good, and we're really happy with the result. So as a take-home message is, it's important to do traction here. Traction does a lot of the work. Teamwork also here is very important. You gotta have a nice ICU team. You gotta have swallowing specialists, physiotherapy services. Do not try these cases in a secondary or primary care center. You gotta go with a tertiary care center if you want to have good results. Thank you.
Awesome, Ignacio. That's a very impressive case. I invite Mike, Matt Goldwyn, and Desmond if they would like to join. I have some question for you about this case. When you define to go to a direct decompression versus just traction and see how it goes, because the decompression you had with the Halo base was phenomenal. Maybe the spinal cord was pretty good enough decompressed to no go anterior. Particularly in this case with a very small mouth, that is a pretty tricky case for going anterior, right? And yeah. If you go anterior, how to manage to or how to define to go through the mouth or endoscopically through the nose? You're a scalp-based surgery, so you're pretty comfortable with both approaches. So how do you find to go from superior to downs, or from the mouth straight to the C2 arc?
I had a partner who does all these endoscopic procedures, and we saw the case together before. And he wasn't sure he could do that through the nose. So since I do, I was trained with Dr. Perrin, and we did a lot, and Dr. Sen also. We in my fellowship, I saw many transoral procedures. I felt pretty comfort with going transorally. So I did that because, the guy who does endoscopic procedures didn't feel that confident in doing that endoscopically. Also, I could have gone without the transoral time. Doing just HaloVest and then OC fusion. But that ligament that the guy had, this hypertrophic buckling PLL, I wasn't sure that just by traction and doing OC fusion, that ligament was going to go apart from the anterior spinal artery. This spinal cord was really damaged before, and I felt pretty confident in decompressing first and then doing the OC fusion.
You plan tracheostomy first, or in advance to surgery, or you do in the same?
When we didn't plan the tracheostomy, when we had the patient in the OR right before the transoral, the anesthesiologist put the camera to intubate the patient, and it was so difficult. The intubation was so difficult that he decided to do a tracheostomy right away, right at that time. I mean, he couldn't manage to intubate the patient. So that difficult was the case.
Oh, it's pretty tricky, guys. Congratulations, that's phenomenal. I have some question from the chat. Sanet Brisa, this says that do you routine prep evaluation for apnea and respiratory function before surgery, or you cancel that to the patient before?
You know, when I have like two visits with the patient and one visit with his parent. They never told me about any kind of respiratory problem before. I should have sent the patient for a pulmonary evaluation before. I'm sure he had some kind of pulmonary dysfunction before the surgery. But I will in the future, actually, because you know the guy developed this hypercapnic respiratory failure that needs a CPAP, and maybe we could have avoided all these respiratory problems the patient had if we had known that before.
That's a good take-home message, right? And so, why so distal to C5? Why you choose the C5 as a lower instrumental vertebra? Might be C4 or maybe C3. What do you think?
As I showed, you know, first we didn't put any anterior support. So these contracts, the contract must bear a lot of pressure and you know, because there's no anterior support. So we wanted to avoid any post-op you know, screw pulling or loosening or whatever. So the guy is very young. He's 25 years old, and he has you know, he has a long life to live. So we wanted to make sure that we were not going to have any construct problems later. And also, as I showed, we couldn't manage to put C2 screws on both sides. If I had had the opportunity to put 2 screws on C2, I would have stopped at C4. But I wasn't that happy on stopping at C4 with just one screw and C2 transpedicular screw.
Awesome. How do you manage the head position when you're doing a OC fusion? Because there may be troubles swallowing or breathing after a kyphotic or maybe a hyperextended position of the head and the occipital cervical fusions. How do you manage the positioning for that?
Well, for this case or in general?
In general.
Well, in general, I measure the Z0, C2 line or the swallow. There's a lot of line, the swallowing line. I use the C0, C2 line, and I have the patient. I send the patient for a pre-op X-ray. I measure the angle, and then at the surgery, I try to copy that same angle. In this case, as I said, I put the patient on a Helovest, and then I had the patient eat for 2 days and make sure the patient had a good swallowing in that position. This is one of the advantages of putting the patients on a Helovest beforehand.
Yeah, you did the posterior surgery with the Helovest in place, and then you have a pre-op test.
Yeah.
Awesome. That was a great case. If you want to go to the second one.
Alrighty. Hold on. So the second one is a C1 fracture case that really was hold on. You guys see my screen?
Yeah, perfect.
So this is a 69 years old lady. He had a history of stroke. He had a left hemiparesis before. He was in a wheelchair. He was severely, you know, paralytic on the left side. He was obese. She was obese, and she had a neck trauma. He felt while trying to go from her bed to the wheelchair. It was a low energy trauma. And this is this lady was referred to my office again with this fracture. And this was the coronal CT scan. You can see the displacements of two C1 lateral masses. And there was a lot of discussion in my department about whether she had or not a ligament. I discussed with with our radiologist, and she felt that the ligament transversus was ruptured. So we classified these fractures as a type 3 with a type 1 injury. So we chose this algorithm. This just for you guys to know, we all know that, but C1 it's very difficult to decide. I mean, it's not a difficult procedure, but the decision is something that really puts you in problems sometimes, because if you show the case to 10 spine surgeons, you're going to end up have like 20 different opinions. So it's very difficult sometimes to decide and talk to the patient. The patient, many of these patients, they shop around, they go to several surgeons. Some guys tell them to put a hard color, other a soft color, other to just to C1 osteosynthesis, others to go to the C2. So it's not easy. One of the papers, this is not something that I showed just for the case. It's something that I think we all should read. Is this paper published in 2020 from the European Spine Journal? It's a German paper with 189 patients with C1 fractures. And again, as in our case, the most frequent trauma mechanism is low energy trauma, same as in our case. The most frequent fracture type is type 3, same as in our case. And look at this graphic. You can see all the different strategies you can have with the same fracture. You see the type 3, the Weyler fractures can be treated with a soft color. It depends on the surgeon, depending on the interpretation of the studies. They can be treated with soft color, rigid color, halo traction, C1 direct osteosynthesis, then C1-2 fusion, then even Z0 C2 fusion. So the alternatives here are a lot, and it's very important to talk to patients and try to gather as many opinions before doing the case. One of the things that really I cannot explain is that when we order an X-ray before, the patient had this kind of imbalance of her cervical spine. So I thought to myself, I have to preserve the deep neck muscles for her to preserve the line of sight. So we had to preserve these muscles. So we did this Japanese technique of moving the obliquous muscles up and down to put the C2 or C1. So we put the patient, we seated the patient. As you can see, she's obese, and we put her on a traction, and we use this kind of technique that was described by Dr. Ames many years ago, in which you can put you put 2 C1 screws and then 2 screws on C2, and then you compress with a crosslink. And this is what we did. We put the patient on traction, and then we put the crosslink in between the screws, because it's not easy to compress, because the occipital bone is really close to the rods. So we managed to put a crosslink between the screws and compress it there. And also, as you can see, we compress over the obliquus capitis inferior muscle. We preserve the muscles, and we could manage to do a nice reduction. This is the post-op CT. You can see the screws there on C1, and then these are our C2 screws. This is the coronal, and this is the pre-op and post-op. As you can see there, the post-op X-ray has a normal sagittal alignment. So this must have been some kind of antalgic posture, and the patient is doing really good. She's pain-free. She wanted to come today to show you guys how good she's doing. Actually, when I told her I was going to present the case, she wanted to show up. So this is, I think this drawing shows the different pathways we can take in C1 fractures. These are not easy cases sometimes to decide what to do. So, any questions about the case?
That was great, Nacho. That was a great case. Do you think matters to do that reduction of the opening of C1 versus just doing the typical hamstring, doing C1, C2 fusion, or not?
Again, my light failed. Again, Alfredo?
Do you think it matters to do that compression of the C1 arc to close it, the ring, or versus doing just the classic C1, C2 fusion? The change?
You saw the lateral masses were spread out, and I wanted to compress the we achieved a nice compression on the right side. The left side is still opened, less open than before, but I think it went like in 1 or 2 years it's gonna accommodate better. And but the patient is asymptomatic, and she had a nice post-op outcome. She went home like 3 days before after the procedure. So I think by closing the C1 ring, it's you put things back to what they were. I mean, you can. It's not that difficult to do that. I mean, we had. I thought at that time that we had to protect these deep neck muscles. So that was a little difficult to do, but we managed to do that.
We have a question. Saleh said he loved the crosslink. The only indication I have for a C1, C2 fixation, but do you always have C1 screw bicortical or just for side cases on unstable C1 fractures?
Again, Alfredo?
Do you typically use bicortical C1 screws or just in these kind of cases?
Well, the thing is, I don't have a C arm, and we don't when the C1 arch is severely displaced and opened as it was, the anatomy changes. It's not easy sometimes to put these screws. And also, we put the patient sitting, and it's not the most comfortable position. I had some, I wasn't that comfort that day, with the patient sitting, the shoulders when you're sitting, but that was the only, position that, I wanted to do the patient, because, she was really obese, and, with the Mayfield traction, it's important to do Mayfield traction before trying to close the C1 ring. And no, I usually put I don't put the cortical screws on C1. The carotid artery is on the other side of C1, so you want to avoid the carotid artery. I have done that many times, but I wasn't looking for that.
Got it. So do you have any tip for putting the C1 screws in these kind of fractures? Because it's kind of tricky when you push the screw, the lateral mass go anterior, so you don't have resistance to go with the screw in, you don't have the pull case to put in that screw. So you drill the entry point, or how you do that?
I use a drill first. When you put C1 screws, it's very important to do an angio CT first and see where the VAs are. If the patient has one VA or two VAs, and if one is dominant or not, and if there's any abnormalities of the VAs, that's of paramount importance. Then I dissect the vertebral arteries above the C1 arch, and I want to see them. I want to see the vertebral arteries. If you want to avoid lesion in them, if you want to avoid the vertebral artery, you want to see the VAs. So I exposed the entry point, and then I used a drill, a small, like 2 millimeter drill, just to do the first hole. So I do that without any pressure. So once you use a drill, and sometimes I do like 30% of the trajectory with the drill, and then I put the primer instruments. Sometimes I do the whole. I've done the whole trajectory with the drill if I feel comfortable, because you avoid pushing the C1 lateral mass. And but I always start with the drill, a small 2 millimeter bore.
And you feel that was a real instability when you're doing the surgery and in between C1 C2?
Yeah.
The TLO was well. Yeah.
I in this case, actually, I put a clamp on the posterior arch of C1, and my assistant was kind of pulling the C1 arch towards the back, so to avoid pushing the C1 arch while putting the screws and the tap. It was really unstable. Yeah. I felt like it was a good decision to do this case. I talked to other to 2 or 3 orthopedic guys in my department. They told me they would have put a heart cutter. The patient was in a lot of pain. She went home 3 days later without pain. So I think it was a good decision. Of course, sometimes you can manage with a heart cutter, but if you have the knowledge and the experience, you can improve their patient's life, the outcome, and by doing this type of procedures.
I love the muscle sparing technique to go to C1 and C2. I never saw that before. Have you seen any difference in the outcome in neck pain or infections using that technique between classic midline approach? Or
a huge difference? Huge. When you cut the it's been documented, but when you cut the C2 muscles, and I mean you detonate all the bone, the patient they suffer from a lot of pain for many weeks, sometimes at least 10 days of severe pain that sometimes requires opioids, OxyContin and all these drugs. But when you preserve the muscles, I'm telling you, the patient went home 3 days later with no pain. I mean, I sent her with NSAIDs. That's it. When you preserve the C2 muscles, the patients it's a world of difference.
Yeah, it's a like wheelchair approach for the lumbar spine, right?
Yeah.
Or cervical, anterior cervical.
Mike, this is the question of doing the percutaneous or mini open tubular C1 C2 fusion. It's much better.
It's muscle sparing. Yeah. Mike, are you there? Have you seen the case?
Yeah, I'm here, Alfredo. That was nice case. Hey, I just wanted to talk. I mean, we got a big audience here, right, about cervical implants. Those are 3.5 millimeter rods, aren't they? For most people, yeah. Mm-hmm. That we're squeezing on and manipulating people's heads on. Do you have a 4 mil system, Ignacio, you use for these bigger cases, or do you still use the 3.5s?
No, this rod was. You mean the screws or the rod?
The rods themselves, the rod diameter.
I think it was I don't quite remember. It was a 3.5 rod. I don't think it was 4 millimeter rod.
You don't have a 4, yeah. I mean, I've always felt that for we could engineer something better, right? Because we put a lot of force on these cervical constructs, and a 3.5 millimeter rod, they're not that strong, right? You easily bend them. You can almost bend it by hand, right? So then we put these do these huge reductions at the craniocervical junction. We've got these really bulky, strong plates with 8 millimeter screws in the occipital keel, and then we connect it up to these 3.5 millimeter rods that I can bend by hand. So I reckon, as the industry that is on this should give us a 4.5 at least. Work out a way to engineer some stronger rods for what we do up here. Because I've actually used 4 rods across the occipito-cervical junction in a revision situation before, just to get that strength there. Because that OC fusion is really hard to get. I think even if you used allograft, for your first case, that OC fusion is hard to get. And for your second case, you're using that powerful compressor over these 3.5 rods. And I think that's an awesome technique. Let's go on 3.5 rod. Are you just going to end up bending the rod more than you bring the bone back together? Do you know what I mean?
That's a good point. You're right. Yeah.
Nice result. Celia is on the chat, just saying, is it titanium or cobalt chrome? Titanium, yeah. I haven't seen too much cobalt chrome for the neck either. I think there's one kit I know that has it on there, but I think, when we're doing these big operations up there, I always think it'd be nice to have like stronger rods, basically, for these surgeries.
Yeah, nice. Particularly for this kind of deformities. Yeah, it's not a degenerative case. Yeah.
Yeah. Very good point.
Mike. So we can move. Yeah.
Okay, my last case, I published it, and hold on, I didn't put the publication. You can look at it on the internet. Let's see. Let's share the screen. So this is a. Do you guys see? Can you see my screen?
Yeah.
So this is a C1 split fracture. Actually, it's a rare fracture. This is a 57-year-old female with a long history of celiac disease and osteoporosis. She suffered a neck trauma and proximal fracture of her right humerus after falling from a church stairs. So she underwent a primary osteosynthesis of her humerus, and then she was discharged on a Philadelphia quarter. And she was referred to our hospital 30 days later after the initial trauma. That was the initial studies. You can see a right lateral mass fracture, and the MRI didn't show any rupture of the transverse ligament. But if you see the right upper coronal image, you can see the condyle, pushing down in between the fragments. So, classifying these fractures are not easy with the AO spine classification. It's not an easy fracture to classify if you don't know what you're treating. So it could be a type A because it's only an isolated bony fracture. But Bradshaw described this specific type of fracture. He called in the sagittal split fracture, and it's an unstable variant of the Jefferson fracture. This is the initial report, and as you can see, this is a sagittal fracture. I mean, this is not going to heal with a cervical collar. So when classifying with these fractures with the AO spine classification, you have to go with the modifiers, because this is a high risk of these fractures have a high risk of non-union. So it's an M2 modifier. So the patient was she was offered an OC fusion. So when she came to my office, I said, I can do an osteosynthesis of that fracture. So since I don't have an O arm, because as you can see on the lower left part of the images, the trajectory of the screw was really medial. I was really afraid of putting that screw. So we developed this guide, this 3D printed guide that guide us the screw, and we ended up putting a wrist screw, and we had a nice fusion of the fracture. You see the three CTs, the three planes, and this is also bicortical. I didn't mean to go bicortical at first, but well, bicortical. And on the right low, you see, as I said before, I dissect the vertebral artery. You can see the vertebral artery there, and then the screw going in the C1 lateral mass. The trajectory was really, really median, and it was really scary, to put that screw. But the results were good. The patient recovered her neck rotation, and so it's important to recognize this C1 split fracture. It's not new, but it was described in 2009. When you have these fractures, don't put the patient on a cutter, because the patients are going to end up with a rabbit deformity, and they're going to end up with chronic pain. So they don't heal with cutter. And if you have the opportunity to do osteosynthesis, you can preserve the motion in the CV junction. And if you don't have an O arm, you can go with these patient-specific 3D printed guides that are low cost and can guide you the screw through these two small fragments. So that this is the case.
Okay. Can you get the post-op image, please?
Yeah, sure.
What are the chances that this patient have neck pain for the C1, C0Z1 impeachment she had?
As you can see, the coronal, she
looks much better. Yeah, but
she came already with that deformity. So, yeah. But I did this case like 2 years ago, and the patient is doing really good. I thought she was going to develop like chronic pain, but she's doing really good, really good. Actually, the marketing department in my hospital, they want to call the patient back, and they called the patient a couple of times to do kind of a interview, and to tell the community her experience. Since she was offered an OC fusion, and the patient is doing really good. I still talk to the patient, and I saw that also, and I wonder why she doesn't have neck pain. But sometimes
it happens. Yeah, that's a lag screw.
It's a lag. You can see it on the lower left. It's a lag. It's a lag screw. I sat for many hours with a rep to see what kind of screw we were going to put, and they offered me this screw from a wrist set, and we put a wrist screw in the C1 arch. So we had to make do with what we had.
Yeah, customized treatment. Mike, do you have any experience about this kind of synthesis of C1?
I have thought about it, but never tried it. It looks really cool. I've actually done similar things to save levels in lower cervical fractures, like a bad burst fracture at one level and a split above it. I've got almost around the side as far as you can and put lag screws across to hold the bone together, and then plate it over the top of that. Use the little scaphoid screws we use in ortho.
Yeah.
As little compression screws. But this looks great. I wanted to ask you, Ignacio, obviously you do a lot of complex upper cervical work. Have you ever done occipital condyle screws?
No, not yet.
Yeah, I've got a case I might have to do them on. So I'm just asking around. Anyone wants to come down to Australia and help me out?
Our hospital is not a kind of a trauma center, so I don't see that many cases. These are.
No, I want to use it as a fixation point for a complex upper cervical abnormality. But
okay.
It's there's doing this stuff without navigation. I think you're doing a great job, because I cheat these days and use nav for all these cases. I mean, if you have an navigation. If you have an O arm,
everything goes smoothly, and you're more confident. But if you don't have an O arm, it's not easy. When I put the guide, the guy guided me the screw so medially that my assistant, you should have seen my assistant's face. Like you're gonna punch her by the board. But and as you can see, the trajectory of the screw is not as medially as I planned it. Because I was scared of putting that screw, but it didn't that well, fortunately.
When you define to do for this kind of case, that's a pretty atypical case, right?
Yeah.
But when you think occipital fusion is needed, because we're seeing less and less fusions to the occiput lately, right? We saw a lot of occipital cervical fusions like 10 years ago, and I don't know why. I maybe have a clue, but we see less and less of these cases today. When you think occipital fusion is needed and you cannot avoid occipital fusion, because we've seen a lot of C1 down fusions a lot now for basilar invaginations, Chiari revision cases, and a lot of craniocervical junction deformities. There are more cervical deformities than craniocervical deformities for sure. So when you think I need to go to the occiput, this is a go.
If you cannot get a nice screw purchase on C1, and you have to go to C0, that's basic. Sometimes the vertebral arteries do not allow you to put 2 screws. I have a case with a C1, C2 subluxation in which the patient had just one vertebral artery, and the other one was completely atrophic. So the vertebral artery didn't allow me to put a C1 screw on one side. So I ended up putting 2 screws on the other side, and the rod broke like 3 months later. Fortunately, the patient didn't have that much instability, and he's doing well. But the thing is, with ossifusion is nowadays the rheumatoid arthritis are well treated with the biologic medication, so we don't see that many cases of rheumatoid arthritis now. And also, surgeons are more and more confident on going to just on stopping on C1. So you have to remember that in the 80s, many of the cases were done with cables, 80s and 70s. And sometimes the surgeon felt that going to the occipital bone was better than ended up with a cable. So nowadays, with all these contracts and the experience that we have with C1, even now you can dissect the vertebral artery, by the C1 and put the screw over the arch, like it's called the OTA technique. I mean, surgeons are getting more confident on putting screws on C1, so that the need to go to the occipital bone, I think it's becoming more rare.
Yeah. Also, the tendency to do cages or graft in C1, C2 facet joint maybe can help for most of the vascular invagination. Mike, what do you think about this tendency toward not going to the occipital?
Oh, I think it's great because I think they're really hard fusions to get, and they're a lot more disabling for patients as well. If you can spare that C0, C1 motion, then I'm all for it. And I think, grafting the joint, I think where navigation has made a change for me in some of these cases is that I actually do a combined like Harms Magrill technique. So with navigation, you can stack a C1 lateral mass screw, and if you can get it reduced or acceptable on table, then you can often pass a C2 pedicle screw across the joint and miss your C1 lateral mass screw just. These are hard to do without nav. And then join them up. So you can basically have a best of both worlds technique. And that is very strong, very strong. And it'd be stronger with a 4.5 mil rod. I call it the Hag rule. I'm sure I didn't invent it, but it's been, it's a nice technique. So it's incredibly strong, and it's even stronger if you can get bigger rod diameters in there, which I think is the weak point of most cervical fixation that we do. But look, advice to younger surgeons would be, try to avoid the occiput if you can. I think that's the key, and obviously cranial settling and cases that, like the first one Ignacio showed there, that you got to do it, but try to avoid it if you can.
And when you did had to go to the occiput because of you lacking C1 screws. Once you get the fusion in the C1, C2, you take out that rod, or you keep it.
Yeah, it depends on what the indication is. I mean, in a post-traumatic setting, absolutely. But the majority of my occipitocervical fusions have been for sort of complex pediatric upper cervical abnormalities, and they're super tough to get diffused, but you can. Sometimes they take a couple of goes. And the other indication would be occipito-cervical dissociation in trauma, and then the odd tumor case as well. So, I mean, it's really not something I try to do too often. Certainly for most patients with a drop head deformity, I would really try to avoid going to the occiput if I can. So by and large, use navigation, try to use whatever fixation options I've got at C1 to try to help. I don't mind using cables or bands if you have to as an augment. Don't know if you guys have ever seen the little technique of using C1 arch screws. You know how you can do C2 laminar screws? There's a described technique of using a highly polyaxial screw and popping it in the arch of C1 if it's big enough as well. So I think there's lots of ways of getting fixation in the area, and just have to mix and match and use what's favorable anatomy in each particular case.
Yeah.
What do you think, Nacho? And what about the graft for these cases? You have BMP, you use ilia graft or ribs, or what do you use?
I use allograft or ribs, and in kids I use ribs. Adults I use allograft. Iliac crest graft I think is good standard, and I'll use that in younger patients. I think when you get to an older patient, above the age of 70, it's not that great. So it's basically a long application process for each individual patient to use it. Now, could have used it routinely up until about 3 years ago, and it got taken off the market. What's it like in Argentina and Southern America for BMP? Easy access, or?
No, we don't have it.
No.
Yeah.
It's not approved of the local FDA, so we don't have it, and it's too expensive. Even if it was approved, it would be pretty inaccessible.
Yeah.
So what about your graft? Sorry, Mike.
Oh yeah. We've got a big supply of allograft here, which is very, very good. So yeah, I'm happy with allograft.
Yeah, so we have
for most of these. Yeah.
And you, Ignacio, what are your choices for graft?
I use that allograft as well, unless it's an autofusion. I was taught in my fellowship to use autograft. Ilia crest or rib is really good because it has the same curvature that you need. And this case, I couldn't retrieve a rib because the patient had the halo. So unfortunately, I had to go to the posterior iliac crest. But I use allograft, so yeah, always.
And what are the fusion rates for this kind of case? Because it's pretty difficult to get fusion in that area, right? Particularly when you go to the occiput. What are your fusion rates? In the literature is close to 80. I have like poor result like that. What are your rates?
I'm working more and more with the endocrinologist and all kind of bone metabolism specialists. So sometimes I put the patients on many medications that for TO. I don't know how you call that in your country, but parathormone and denosumab.
Teriparatide,
yeah, teriparatide.
Yeah, because most of these patients are pediatric congenital deformities or rheumatoid arthritis patient that they had a baseline problem, right? The fusion rates are already poor, worse than typical cases. What about you, Mike? You have the endocrinologist pre-counseling for these kind of cases, not a trauma case, but a patient with a baseline problem.
Yeah, I really utilize that. I mean, we have, I learned about using Forteo from this meeting. from our colleagues in the US that use it routinely for adult, adult degenerative deformity, basically. And I really enjoy, the results I'm getting with that, particularly because we can't use BMP here anymore. So I think that those parathyroid hormone type medications, analogs are very good. And we do need endocrinology help here or physician help to prescribe them. They don't trust me as an orthopedic surgeon to prescribe those kind of medications. I'm not looking at all the blood tests and all the other things you have to do to prescribe that kind of stuff. So we've got a big team of people that look into all that for us here, which is great.
We have another question. If some of you guys use hooks for a salvage case with tricky cases for C1 screws. It can be used sometimes, but when the posterior arc is fractured, it's not a possibility, but not in fracture cases.
Not my first choice, but I've used it once. There's a construct from Ulrich, the German company. They have this. It's a hook, kind of a claw attached to a rod. Have you seen that?
Yeah,
it's a nice construct. I mean, if you cannot go to the C1 lateral mass, but it doesn't have the same strength, of course.
It's like a wiring, right?
It's a hook rod or something like that.
I use that. Yeah, it's a rod included with the hook.
Yeah.
So well, that was a phenomenal case, Ignacio. If you have any other question, Mike, we are on time.
No, that was great. Thank you, Ignacio. Thanks, Alfredo.
Okay. Thank you for the invitation.
It was great to have some.
Have a good night.
See you guys.
Bye-bye.